everyone, welcome to Try Right. This is Pack 365, myself Srija. So today in this session you are going to learn about the anesthesia reimbursement and how will be the modifying circumstances and the qualifying circumstances under anesthesia and also the code ranges for anesthesia. So coming to the explanation of modifier unit values. So what are modifier unit values? So ASA physical status modifiers P1 to P6, they show how sick a patient is. So each modifier may add extra units to anesthesia billing. So more the units, more payment. So because more skill and risk are involved. So P1 and P2 has 0 units. That is low risk patients. So what does that mean? So patient is a healthy P1 or he has a mild and well controlled disease P2. So these conditions do not increase the anesthesia difficulty. So examples like a healthy patient and controlled BP or diabetes. So now why 0 units? Because there is a minimal risk and there is no extra monitoring needed. Whereas P3 for 1 unit, moderate increase in the complexity. So patient has a serious disease that can affect anesthesia. So it also needs extra monitoring and care. For example, uncontrolled diabetes, stable heart disease and COPD. So why 1 unit means moderate increase in the complexity. Coming to P4, 2 units, 2 modifier units. So patient has a severe disease that is a constant threat to life and anesthesiologists must be extra alert at all the times. So examples like severe heart failure and advanced kidney or lung disease. So why there are 2 units for P4? Because it has a high risk and continuous monitoring needed for P4 patients. So P5 is allotted 3 units, extremely high risk. So patient is critically ill in these cases and surgery is the last chance for survival. So examples like massive trauma, ruptured aneurysm and severe shock. P6 for 0 units. So patient is brain dead in this condition. So surgery is done only to remove the organs. So why 0 units? Because no anesthesia risk is related to patient survival and it is only special for transplant billing applies. So here is an example. So patient is ASA P4 and procedure is done lower gastrointestinal endoscopic procedure and the base units allowed are 3. So the modified units for P4 is 2. So how would you calculate the anesthesia time? 3 base units plus 4 time units plus 2 P4 units gives total 9 units. So these total 9 units are then multiplied by the conversion factor to calculate the payment. So this is how you have to calculate with the modifier units. So anesthesia payment is calculated using the units. So these units always show what procedure was done, how long the anesthesia lasted and how sick the patient was. So always remember, more the units, the higher the payment. And there are 3 parts of anesthesia units. So the 1 is base units, 2 is time units and 3 is modifier units. So base units are nothing but they are fixed number based upon the type of procedure. Time units, they are based upon the length of anesthesia time, and physical status modifier units, they are added based upon the patient's health condition. So those are assigned by the anesthesiologist. So here there is an example scenario. So a patient with uncontrolled diabetes undergoing major surgery would receive a P3 modifier. If the base anesthesia code 00810 has 3 base units and there are 4 time units, so the modifier P3 might add an additional unit. So this would result in total units is 3 base units as given in the example and there are 4 time units and P3 modifier. So for P3 modifier, we are adding 1 more unit which gives total by 8 units. So compared to P2 or P1, P3 gives higher payment due to increased risk. So in this, what is conversion factor? So a rupee or a dollar value per unit which is set by Medicare or insurance payer. So every code, every CPT code of anesthesia has a dollar value per unit, which gives the final payment for anesthesia service. So anesthesia reimbursement formula. So what is anesthesia reimbursement formula? So anesthesia payment is B plus T plus M. So B stands for base units, T stands for time units, and M stands for modifier units. So this into conversion factor. So the conversion factor is the total anesthesia units. So you have to add all the units first, then multiply by the money or by the conversion factor value per unit. So base units B, it depends upon type of surgery. It comes from anesthesia, CPT code, and it does not change for the procedure. Whereas time units, it is based on how long the anesthesia was given. Usually 1 unit is 15 minutes, which is a payer dependent. For example, 60 minutes of anesthesia means it takes 4 time units. And modifier unit. So it is added based upon the patient's health condition. It also comes from ASA physical status P modifiers. So P3 patient has 1 modifier unit. So step 1, you have to add the units. Step 2, you have to apply the conversion factor. So if step 1, adding units, it gives 10 units. So in step 2, you have to multiply 10 units into, for example, a conversion factor is $100 per unit. So $100 into 10. So the final anesthesia payment is $1,000 or $1,100. So this unit tells the work done, conversion factor tells the money converted. So what is the conversion factor? So the dollar value of one anesthesia unit, which is decided by Medicare, private insurance, region or state. So this changes every year and by the payer. It gets updated by every year. And the fourth is qualifying circumstances. So now what are the qualifying circumstances? These are the special add-on CPT codes which ranges from 99100 to 99140. So these are used when anesthesia is more difficult or risky. So these codes describe special situations but not the procedures. So 99100 code, it is for anesthesia for a patient under 1 or over 70 years of age. So this is used when patient is under 1 year and over 70 years. Why? Because very young and elderly patients are more sensitive to anesthesia. So they need more careful monitoring. So many payers, including Medicare, do not pay extra for 99100 code. But it is still important for documentation. And next code is 99116. Anesthesia with total body hypothermia. So in this case, the patient's body temperature is intentionally lowered. So this is used in heart surgery and brain surgery. And hypothermia, it protects the organs but increases the anesthesia complexity. For example, a heart surgery where a body temperature is lowered to protect the brain. And 99135 code, anesthesia with controlled hypotension. So in this case, the blood pressure is intentionally lowered and it is done to reduce the bleeding. It improves the surgical visibility, for example, ENT or a spine surgery with controlled low blood pressure. 99140, anesthesia complicated by emergency conditions. So this is used when surgery is an emergency. So there is no time for full preparation. Patient may be unstable. Example, road traffic accident. So it comes under emergency surgery. So now can we add more than one qualifying circumstances? Yes, more than one qualifying circumstances code can be reported together if supported by the documentation. And here is an example. Anesthesia provided to 75-year-old patient undergoing emergency surgery. So 99100 and 99140 could be added for additional units. So what is the answer? Yes. So 99100 and 99140 both can be added. One for extreme age over 70 years and another for emergency condition. In this 99140 denotes emergency condition. So each code may add one extra unit which is a payer dependent. So what is the important coding rule here? Qualifying circumstances codes, they do not replace ASA modifiers. They are add-on codes only. So many payers, including Medicare, may not pay separately, but documentation is still required for the cases of qualifying circumstances. This must be clearly documented by the anesthesiologist or the person who takes over the surgery. And there are types of anesthesia. So based upon types of anesthesia, the billing will be dependent. So what is the first type of anesthesia? General anesthesia. So in the cases of general anesthesia, patient is completely unconscious. So these are used for major surgeries, airway support required. For example, open abdominal surgery as well as heart surgery. That is, patient sleeps completely in the general anesthesia. Whereas in regional anesthesia, this anesthesia, it numbs only a large area of the body. So patient may be awake or lightly sedated. For example, spinal anesthesia for lower body, epidural anesthesia for labor pain, and arm or leg blocks. And the third type of anesthesia is monitored anesthesia care. So what is MAC? What is MAC? So MAC means the patient is sedated, relaxed and sleepy, but the patient can still respond when spoken to vital signs or continuously monitored by an anesthesia provider. So where is this MAC commonly used? In outpatient daycare procedures or minor to moderate procedures, for example, like endoscopy, colonoscopy, cataract surgery, and as well as minor orthopedic procedures. Documentation and CPT coding. So each type of anesthesia, general, regional, and MAC requires proper documentation and correct CPT anesthesia code. So sometimes combinations are used, for example, MAC with local anesthesia. And example is for spinal surgery using general anesthesia. So CPT code is 00630. So this covers the anesthesia for procedures on the lumbar spine. So anesthesia CPT codes, they are based upon the surgical site, not the surgeon CPT. And next is anesthesia modifiers. So they are special modifiers for anesthesia. So there are two character codes which are added to anesthesia CPT code. So they explain who provided the anesthesia, how it was provided, under what circumstances anesthesia was provided. So why are modifiers important? Because they tell the payer, was anesthesia done personally? Was it medically directed? Was it supervised? Was the service partial or complete? So coming to first modifier, AA. So AA modifier indicates anesthesia services personally performed by an anesthesiologist. So no delegation to CRNA, no delegation to anesthesia assistant and other providers. So anesthesiologist evaluates the patient, administers the anesthesia, monitors the patient and manages the recovery. So there's no other provider involved. So you have to use AA modifier in these cases. So next is QK modifier. So it involves medical direction of 2 to 4 anesthesia cases at the same time. So in simple words, a physician, anesthesiologist is supervising 2 to 4 CRNAs at once. So the doctor is not doing everything personally, but he is medically directing the multiple cases. In this, who is involved? Physician, whether the physician is MD or a DO, and 2 to 4 CRNAs working at the same time. For example, one doctor supervises 2 CRNAs giving anesthesia in 2 different operation rooms at the same time. So in this case, the modifier used is QK. And coming to QY modifier, it involves medical direction of 1 CRNA by a physician. So here a physician supervises only 1 CRNA. So the doctor handles only 1 anesthesia case at a time. So who is involved? Physician and 1 CRNA as well as a 1 patient. Example, a doctor supervises 1 CRNA during a surgery. So you have to assign modifier QY. And we also have QZ. So QZ is CRNA service without physical medical direction. So the CRNA works independently. There is no physician supervision. So who is involved? Only CRNA and no anesthesiologist directing. For example, a CRNA provides anesthesia alone in a hospital or a surgery center. So the modifier allotted is QZ. And next is modifier 53, discontinued procedure. So a procedure starts but it is stopped. So it is stopped because of the patient's safety or unexpected problem. The doctor did not complete the procedure. So this is important for anesthesia. Anesthesia began, surgery or procedure had to stop early. So what will be the common reasons? Maybe patient has breathing problems, drop in the blood pressure, or allergic reaction, or a medical emergency. So example is anesthesia is started but patient develops the complications. Surgery is stopped for safety. So for this you have to assign the modifier 53. And next modifier is 73. Discontinued outpatient procedure prior to anesthesia administration. So prior denotes before. So in these cases, patient was prepared, patient was taken to operating or procedure room, but anesthesia was not given. Procedure was cancelled before the anesthesia. So everything was ready, but no anesthesia started. So the procedure was stopped. So when to use this? Only for outpatient or ambulatory procedures. So cancellation happens before anesthesia induction. For example, a patient is prepped for surgery, changes into hospital gown, IV line started, taken to operating room, and suddenly he has high BP. So surgery cancelled before the anesthesia. So in this case, you have to use the modifier 73. And what is modifier 74? Discontinued outpatient procedure after anesthesia administration. So patient was prepared, anesthesia was given, and procedure was cancelled after anesthesia. So anesthesia started, but the procedure could not be completed. So when to use? Only for outpatient procedures. Anesthesia is already administered. There is an example, a patient taken to OR, given anesthesia, he develops a breathing problem and surgery stopped for safety. So which modifier you have to allot? 74. And modifier 47, anesthesia by surgeon. So surgeon gives the anesthesia in these cases. There is no anesthesiologist or CRNA involved. So usually local or regional anesthesia was given by the surgeon. So same surgeon does the surgery and gives the anesthesia. So do not use modifier 47 on anesthesia CPT code. So you have to allot the modifier 47 on the surgery CPT code only. So remember, 47 should not be given to the anesthesia code. You have to give only to the surgery CPT code. So for example, surgeon performs a minor procedure, surgeon injects local anesthesia themselves. So what is the correct coding? You have to give the surgery code, for example 45278, and for that code you have to assign the 47 modifier. So why modifiers like QK, QY, AA, 53, 73, 74 and 47 are used? So modifiers are the extra codes added to CPT codes to explain who gave the anesthesia, who supervised, whether the procedure was stopped or continued, and any special or unusual situation. So QK, QY and AA explain who provided the anesthesia, whereas 53, 73, 74 explain what unusual situation was happened after giving anesthesia or before giving the anesthesia. So this helps the insurance companies to understand the exact situation so they can decide correct payment. And coming to basic monitoring services. So what does basic monitoring mean? So these are the routine checks done for every anesthesia patient to keep them safe. So these are included in anesthesia payment. So they are not billed separately. So what are the types of basic monitoring? Pulse or blood pressure monitoring, which checks heart rate and BP, and it also ensures patient is stable. Second is ECG, electrocardiogram or electrocardiography. So it monitors the heart rhythm. It detects the abnormal heartbeats. And third is temperature monitoring. It ensures body temperature which stays normal. It also prevents hypothermia or overheating. Local or topical anesthesia, which is part of a general anesthesia. So what does this mean? Local anesthetic injections, topical numbing agents, and nerve works used as a part of general anesthesia. So this is included in the anesthesia service. This is not billed separately if a part of anesthesia plan. So general anesthesia plus local numbing at incision site is an example. So you have to do not bill it separately. So what are the additional services which are not included in anesthesia billing? So what does this mean? Some procedures are extra, more complex, not routine. So they can be billed separately. For example, what are those? Swan-Ganz catheter insertion. So this is an advanced heart monitoring catheter which is used in critical or higher risk patients. This is not done for every anesthesia care. So this can be billed separately, not included in the standard anesthesia fee. What is CVC? A long tube placed into a large vein in the places of neck, chest or ground. So this is used for giving strong medicines, large fluid or blood transfusions, monitoring heart and as well as blood flow. So why it is not included under general anesthesia codes? It is a separate invasive procedure. So the CVC, it requires skill, time as well as risk. For example, during a major surgery, anesthesiologist inserts a certain line in the neck. So you have to bill separately using CPT CVC code. Next is transesophageal echocardiography, TEE. So what is TEE? It's a special heart ultrasound. So it is a probe which goes through the mouth into the esophagus, which gives clear images of the heart. So when it is used for cardiac surgeries, for high-risk patients to monitor the heart function during the surgery. But why TEE is not included? Because it is a diagnostic imaging procedure. It needs special equipment and training. Example, during heart surgery, anesthesiologist performs TEE to monitor the heart function. So in this case, you have to bill TEE separately. And third is nerve blocks for post-surgical pain management. So anesthesia for surgery is included. So nerve block for post-operative pain, this can be separately billed. So examples like surgery done under general anesthesia. After surgery, anesthesiologist gives a nerve block for pain relief. So this may be billed separately if documented properly. Ultrasound guidance for needle placement. So what does this mean? Using ultrasound machine to guide nerve blocks to help place central lines to assist the vascular access. So why separate billing? Ultrasound guidance is a distinct service, requires image storage and documentation. So example like ultrasound used to guide a nerve block. So ultrasound guidance CPT code can be billed separately only if there is a proper documentation and not bundled into the main procedure. And the fourth is cardiac output monitoring, which is other than the Swan-Ganz. So what is cardiac output monitoring? It measures how much blood the heart pumps per minute. So it also helps to assess the heart function during high-risk surgeries. So other than Swan-Ganz means the devices other than the Swan-Ganz catheter. So example like minimally invasive cardiac output monitors. So why it's not included? So these are the advanced monitoring techniques which are not used in the routine anesthesia cases. So that's why they can be billed separately. And fifth is epidurals for labor and delivery, not surgical anesthesia. So what does it mean? Epidural given only for the pain relief during the labor. So this is not given for a surgical procedure like C-section. So what is an important distinction here? Epidural for surgery, it is a part of anesthesia. Epidural for labor pain, it is a separate pain management service. Example, pregnant woman in labor receives epidural for pain control. So it is billed separately. And sixth is pain management services, which are not a part of procedural anesthesia. It is separate from anesthesia. So now what are the pain management services? Which are extra pain control procedures, which are done before or after surgery, which are not a part of the main anesthesia service. So examples like post-operative nerve blocks, pain control injections, and continuous pain catheters. So the billing rule is, if it is done separately, you have to bill separately. If it is a part of anesthesia plan, it has to be bundled. So there is a separate timing for separate billing. And next guideline regarding is documentation essentials, which is very important. So why documentation matters? Because if it's not documented, it's not billable. It prevents denials and audits. So what documentation must include? If in the case preoperative, it includes patient assessment, ASA status and anesthesia plan. In the case of intraoperative, it includes type of anesthesia, start and stop times, monitoring used and complications if any are present. And in the case of post-operative, there will be a patient condition, pain control and recovery notes. So why anesthesia documentation is important? Because insurance companies may anesthesia based upon the time, complexity and provider rule. So if details are missing, claims can be denied or underpaid. So what is the golden rule? If it is not documented, it didn't happen. So what are start time, end times? So what does this mean? So exact time the anesthesia begins and exact time the anesthesia ends. So why it matters? Because anesthesia payment is a time-based payment. So even small errors affect the reimbursement. Time must be clear and exact in the cases of anesthesia. Second is anesthesia type and dosage. So why should be documented? Why the type should be documented? General, regional, MAC and local. So amount, how much the dosage of drugs is given. So why it matters? Because it confirms the level of anesthesia. It supports the correct CPT and modifier use. Example, general anesthesia with propofol and fentanyl, the dosage is recorded. And third is patient's physical status and any relevant modifiers. So what is ASA status? A system that shows how sick the patient is. So ASA 1 is healthy, ASA 2 mild disease, ASA 3 severe disease, ASA 4 life threatening, ASA 5 not expected to survive and ASA 6 is brain dead, which is similar as P modifiers. So why it matters? Higher the ASA P modifiers, higher will be the complexity. So this may affect the reimbursement. And the fourth is qualifying circumstances, if any. So these are the special conditions that increases the anesthesia difficulty. So this document, it justifies the additional payment. It also supports the special modifiers. And modifiers for multiple providers. What does this mean? So it is a document who gave anesthesia, who supervised, and the number of providers involved. So common modifiers are AA, QK, QY, and QZ. So modifiers always explain who did the work, who performed the surgery. Example, a 75-year-old patient with heart disease undergoing complex heart surgery. So these are the documentation essentials related to anesthesia. So this is for today's session. So in the next session, you're going to learn about what are the common errors to avoid while coding anesthesia and the code ranges related to anesthesia in detail. Thank you.